بسم الله الرحمن الرحيم. أعزائي طلبة المرحلة الخامسة، السلام عليكم. Today we will discuss another entity of renal disease, and that is the tubulointerstitial diseases. Tubulointerstitial diseases are a group of diseases that might be caused by inflammatory reaction, by inherited causes, or it may associate other diseases. All these may affect the renal tubules and the surrounding interstitium. That's why we call it tubulointerstitial diseases. There is affection of both the tubules and the interstitium surrounding these tubules. Regarding the clinical presentation of tubulointerstitial diseases, it is often a presentation with manifestation or clinical features of renal impairment. The findings in urine with patients with tubulointerstitial diseases are: number one, we have proteinuria, which is generally low level. The protein creatinine ratio is less than 100 milligram over millimole. It is not like the proteinuria that we used to find in glomerular diseases. In glomerular diseases, the blood urea is more severe, and sometimes it reaches a nephrotic range and the patient may develop nephrotic syndrome. Also, in tubulointerstitial disease, we may find red cells and white cells and white blood cells in urine. For such entity of tubulointerstitial diseases, we have two main types. We may have acute interstitial nephritis and we may have a chronic interstitial nephritis. Now we will discuss the first entity, which is the acute interstitial nephritis. And simply it is defined as acute inflammation within the tubule and the interstitium surrounding them. Regarding the etiology of this entity of interstitial nephritis, which is the acute interstitial nephritis, the causes of this might be allergic. And the allergic causes is mostly due to drug allergy. Or it might be due to toxins. Some toxic material might contribute to the acute interstitial nephritis. Or it might be due to other diseases or infections that might be associated with acute interstitial nephritis. In the next slide, we will see in more detail the causes of acute interstitial nephritis. Here, under the heading of allergic causes, we may have a drug, and as we have said, the common allergy is due to medicine or drugs. Among these drugs are penicillins, non-steroidal anti-inflammatory, proton pump inhibitor, mesalazine. And the second group of causes is the immune causes. And an example for these causes is the autoimmune nephritis and the kidney transplant rejection. The third group is the group of infections. Acute bacterial pyelonephritis is due to infection. Leptospirosis, tuberculosis, which is still endemic disease in our country, might be a cause for acute interstitial nephritis. Hantavirus might be a cause for this disease. And the fourth group of causes is the group of toxic materials. In multiple myeloma, the light chains being excreted in urine in large amount, they might cause acute interstitial nephritis. Mushrooms might be sometimes poisonous or toxic and may cause acute interstitial nephritis. And as we have said, the exact diagnosis of kidney disease usually comes after renal biopsy and histopathological examination. What do you expect to see in renal biopsy taken from a patient with acute interstitial nephritis? The findings on renal biopsy might be intense inflammation with polymorphonuclear leukocytes and lymphocytes surrounding the tubules and blood vessels and invading the tubules. Also, in the renal biopsy of a patient with acute interstitial nephritis, occasional eosinophils might be seen, especially in a drug-induced disease. Also, the degree of chronic inflammation in a biopsy is a useful predictor of the eventual outcome for renal function. Sometime in a renal biopsy from a patient with acute interstitial nephritis, we may see evidences of a chronic inflammation. Such findings may give us a hint or a clue that this patient may develop chronic renal disease in the future. This slide shows you the allergic interstitial nephritis. What do you expect to see in allergic by renal biopsy in allergic acute interstitial nephritis? As you see, there is extensive mononuclear cell infiltration. The glomeruli are spared, they are not affected. Sometimes eosinophils are prominent. Such finding might be seen, or similar finding might be seen in renal biopsy from a patient with kidney transplant rejection. Here, this slide shows you the normal tubular histology, so that you may compare the findings in the first slide with such normal tubular histology slide. How to manage a patient with acute interstitial nephritis? According to the golden rule in medicine, whenever you have an underlying cause, you should remove. And here, some patients with a drug-induced acute interstitial nephritis recover following withdrawal of the drug only. So sometimes to stop the drug is the only measure that a patient may need. And you don't need to give further measures for a patient with acute interstitial nephritis if it is due to drug-induced interstitial nephritis. There is a place for steroid therapy sometimes in acute interstitial nephritis, and a prednisone of 1 mg per kg accelerates the recovery and may prevent long-term scarring. And once the patient with acute interstitial nephritis presents with acute renal failure, dialysis is sometimes necessary, although it should be of short term or for short term. Other specific causes or diseases or infections should be treated if possible, of course. The other entity of interstitial nephritis is the chronic one. It's called the chronic interstitial nephritis. And the causes for this are the following. Such disease may follow acute interstitial nephritis, or it may follow glomerulonephritis, or chronic interstitial nephritis might be a sequelae for immune inflammatory reaction, such as the situation in sarcoidosis, Jordan syndrome, systemic lupus, chronic transplant rejection, or sometimes toxic substances or materials may be a contributory factor for chronic interstitial nephritis, such as lead poisoning, mushroom poisoning, and so on. Drugs, especially among patients on maintenance drug therapy, may contribute to the development of chronic interstitial nephritis. drugs like lithium toxicity, analgesic nephropathy, cyclosporines, infections, as we have said. Sometimes chronic interstitial nephritis may be a consequence of severe pyelonephritis. The seventh group of causes is the congenital and developmental causes, like vesicular-ureteric reflux, renal dysplasia, Wilson disease, medullary sponge kidney, sickle cell nephropathy. All these may cause or may contribute to the development of chronic interstitial nephritis. And the eighth group is the group of metabolic and systemic diseases: hypokalemia, hypercalciuria, hyperoxaluria, amyloidosis. All these may contribute or may be causes for chronic interstitial nephritis. Now, what are the clinical, what are the biochemical features of a chronic interstitial nephritis? The first fact to know is that most patients with a chronic interstitial nephritis present in adult life with a chronic kidney disease, with hypertension, and on abdominal ultrasound imaging or other imaging, small kidneys as well. And keep in your mind that the chronic kidney disease is often moderate. And by moderate, we mean stage 3, for example. But because of the tubular dysfunction, electrolyte abnormalities are typically more severe. Although we have a patient with a stage 3 chronic kidney disease, but there is severe hypokalemia and acidosis. This is because of tubular dysfunction. Checking the urine or urine examination in a patient with a chronic interstitial nephritis is not informative. There are no specific abnormalities in urine that is suggestive or diagnostic of a chronic interstitial nephritis. And because of impairment of urine concentrating ability and sodium conservation, these will put the patient with a chronic interstitial nephritis at high risk of superimposed acute renal failure with even moderate salt and water depletion during an acute illness. So because of disease tubules, because of loss or impairment of concentrating ability and sodium preservation or conservation, these patients may develop acute renal failure with even moderate salt and water depletion during an acute illness, for example, gastroenteritis. The other finding in chronic interstitial nephritis is that hyperkalemia, which may be disproportionate in chronic interstitial nephritis or in diabetic nephropathy. This is because of hyporeninemic hypoaldosteronism. In chronic interstitial nephritis, the renin secretion is less than normal, and consequently the aldosterone secretion from the suprarenal gland will be less than normal, and this will lead to hyperkalemia. Renal tubular acidosis is most often seen in myeloma, sarcoidosis, cystinosis, amyloidosis, and Sjogren's syndrome. The other entity of nephropathy or tubulointerstitial nephritis is the sickle cell nephropathy. And you know, sickle cell disease is one of the hemoglobinopathies, and it is frequently seen between now and then in the daily practice. In the kidney, these changes, which are due to sickle cell nephropathy, are most pronounced in the medulla, where the vasa recta are the site of sickling because of hypoxia and hypertonicity. Loss of urinary concentrating ability and polyuria are the earliest changes. With sickle cell nephropathy, the earliest symptom a patient may present with is polyuria. Also, added to polyuria, the patient may have distal renal tubular acidosis and hyperkalemia, as we have mentioned before. The other fact about sickle cell nephropathy is papillary necrosis. It is common, very common among patients with sickle cell nephropathy. But minority of patients with sickle cell nephropathy may proceed to end-stage renal disease. Also, patients with sickle cell trait have an increased incidence of unexplained microscopic hematuria and occasionally overt papillary necrosis. Thank you very much.